We want to go a little bit further down, and we want to talk a little bit about the acute complications of diabetes mellitus, and we want to talk about the one associated with type 1 diabetes, which is diabetic ketoacidosis, and the other one associated with type 2 diabetes, and this is hyperosmolar hyperglycemia. And I said before that this only occurs, diabetic ketoacidosis only occurs with type 1 diabetes. I know everybody has seen some cases where people with type 2 diabetes, if they develop sepsis or they haven't taken medications for a long time, may develop mild diabetic ketoacidosis. But for step 2, you're going to know that type 1 is associated with DKA and type 2 is associated with hyperosmolar hyperglycemia, and that's really the end of the story. Now we want to go and I want to give you 2 cases and just make sure you understand a couple of concepts here. So a 19-year-old man comes to the emergency department with increasing weakness and with lethargy for 2 days. He has been complaining of being thirsty and going to the bathroom to urinate constantly. His temperature is 101, so it's a little bit elevated. His blood pressure is on the low side, 98/64. His pulse is elevated, 130. His respiratory rate is elevated at 28 per minute. He's lethargic. Physical examination shows no jugular venous distension, equally round and reactive pupils, and clear lungs. The heart shows regular rate and rhythm but is tachycardic, and the abdomen is benign. Neurological examination shows no obvious focal deficits. So, a couple things on the labs. You'll notice that his sugar is 426, so that's definitely elevated. His potassium is high, 6.1. The upper limits of normal of potassium is about 5.5, so this is elevated. His BUN is elevated, and his creatinine is mildly elevated. His bicarbonate level is decreased, it's 12. A normal bicarbonate level is 24. And then his sodium is 130 and his chloride is 100. So let's analyze a couple things here. So this guy's 19 years old with a comes in lethargic and all that stuff. So he's got diabetes, and just from the age group, you know that this is likely going to be type 1 diabetes because he's young. He's 19 years old, likely, right? We don't know for sure. We're going to find out now. So a couple things that you notice, his sugar's high, but it's not tremendously high, and this is typical for diabetic ketoacidosis. You don't see sugars in the thousands. That's something you see with hyperosmolar hyperglycemia. In diabetic ketoacidosis, you usually see sugars in the 400s, in the 500s. You also notice a couple of things more. You notice that this patient has a low bicarbonate. Low bicarbonate. So the patient likely has metabolic acidosis. The only way I could confirm this is if I do an ABG to confirm that the pH is less than 7.4. But I could do one more thing here. I could measure the anion gap. The anion gap in this patient is 130, the sodium, minus the chloride plus the bicarbonate, right? And that works out to be something like 18, right? So 112, if you subtract that from 130, right, that's 18. A normal anion gap is 12. That's the normal anion gap. I don't like to use the potassium. You don't have to use the potassium. It makes things easier. And if you don't use the potassium, a normal anion gap is 12 or less. This patient's anion gap is 18. So this patient has a high sugar with an elevated anion gap and a low bicarbonate. He likely has diabetic ketoacidosis. This wouldn't happen in hyperosmolar hyperglycemia because they don't develop an acidemia. They don't develop high anion gap acidosis. You also notice a couple of more things that we may be asked on the boards for. One thing is they ask about this, the BUN creatinine. So you could see a couple things here. You notice that the BUN is really elevated, but the creatinine is not so much elevated, and that usually occurs in prerenal azothemia. Prerenal azothemia, when you have a ratio of BUN to creatinine over 20:1, it's usually prerenal azothemia. Usually, but not always, but that usually points to prerenal azothemia. Now, in this patient, they may ask you, what is the only type of cause for this patient's elevation in BUN creatinine? And what they're really getting at is, if this patient is presenting now with diabetic ketoacidosis, they likely don't have kidney disease before this because they've only had the diabetes only for a couple of weeks. That's all you could live for without insulin. You can't live more than a couple of weeks without insulin. So the only cause, unless this guy's got another disease, which is very unlikely, unless he's got another disease, the only cause of this type of elevation in this patient, because he has diabetic ketoacidosis, and I know he can't have diabetic nephropathy because he hasn't had the diabetes for a long time, the only cause of this is prerenal azothemia. So they tell you, what is the cause of this? Prerenal azothemia. How are you going to treat this? You're going to give him a lot of water and reverse this. The third thing that they like to ask us is about this potassium here. And they may ask you, well, what are you concerned about this potassium? Well, you're probably a little bit concerned. It's elevated. But what's the cause of the potassium? The answer is the cause of the elevation of the potassium is due to two things. One, the acidemia. Remember, acidemia or acidosis and acidemia drive potassium out of the cells into the serum, into the extracellular fluid. So you get hyperkalemia. And then the second one, which is more important, is the lack of insulin that we see in patients with type 1 diabetes. The lack of insulin causes hypercalcemia. It drives potassium out of the cells again, and is probably more important than the acidemia in type 1 diabetics. So let me say this again. There's two factors. The one that's more important is the lack of insulin. The other factor is the acidemia. This is because there's two factors in patients with diabetic ketoacidosis. This is why we commonly see hyperkalemia in patients with DKA, and this hyperkalemia resolves once you give the patient insulin and once you reverse the acidemia, which you're going to have to do that to treat the diabetes. So if they tell you, what do you do about this hyperkalemia? The answer is, I'm going to treat the diabetic ketoacidosis. I'm going to have to treat that, or else the patient's going to die. I'm going to have to give him insulin and water and stuff like that. So that's how you reverse that. Now, please be very careful. This is usually what happens in people with diabetic acidosis. We see a hyperkalemia that reverses once we put the patient on insulin. So this is an expected response. Don't when you see this, don't get don't get nervous. Treat the diabetic ketoacidosis, and that's going to reverse right away. Don't give the patient any potassium binders or anything like that. That's the wrong answer. Treat the diabetes. What they ask sometimes is, though, what if this patient has a normal potassium? Normal, I mean, normal for serum levels, normal, but it's not normal for DKA, because DKA patients, I told you, have higher potassiums. What if you see, for example, a potassium of 4.1 instead of 6.1? What do you need to worry about? The answer is, you need to worry about that once you reverse the diabetic ketoacidosis in this patient, once you start to give him insulin and all that stuff, this patient's potassium is going to go 4.1, 3.1, 2.5, and they're going to develop severe hypokalemia. So these patients that present with diabetic ketoacidosis and a normal potassium, it's not really normal. These patients really have hypokalemia. I don't know why they have hypokalemia, but they got hypokalemia. And what you need to do in this patient is, when you give them the fluids initially to treat the diabetic ketoacidosis, you have to supplement the potassium in the fluids. So please be careful of that. A high potassium in diabetic ketoacidosis is expected. It's treated with insulin. If the patient has a normal potassium level, start to replace the potassium from the beginning, because they're going to develop severe hypokalemia as you treat the diabetic ketoacidosis. So I hope everybody understands that. So a couple more things. I want people to think, why this is part of the workup here. This is part of the workup. This is very important. What are they getting at? Why are they getting chest x-rays? Why are they getting blood cultures? Why are they getting urine analysis? The UA here is for urine analysis right here. Why are they, this is all pending, why are they looking for this? And are these the right tests to do? And the answer is yes. So when patients present with diabetic ketoacidosis or hyperosmolar hyperglycemia, we always ask a question, what is the precipitating cause? Did something tip them over? I mean, they were going to get diabetes anyway, but did something tip them over? Like what? Like an infection. In older patients, silent myocardial ischemia may tip them over. So in young patients like our 19-year-old here, it's infections. Remember, this guy had a 101 fever, so he probably had some kind of infection. So what kind of infections do you look for? Common infections in the blood, in the urine, in the lungs, pneumonia, and stuff like that. This patient actually had a pneumonia. This is a real case that I had seen some time ago. This patient had a pneumonia that wasn't picked up. And what happens with when they develop some kind of infection, remember the infection stressed the patient, right? Your cortisol levels increase, and when the cortisol level increase, now your insulin levels need to go up, and they can't compensate. They can't compensate the insulin demands, so they develop diabetic ketoacidosis. So after you diagnose diabetic ketoacidosis or any form of hyperosmolar hypoglycemia, and you go through the numbers and make sure everything is okay, the next thing that you do is you look for a precipitating cause of the diabetes, especially infections in older patients, infections plus silent myocardial ischemia. So you have to do that because they ask that on the boards, and clinically we have to do that all the time. Now a little bit further down with this case, what do we do in this case? We admit the patient to the intensive care unit. That's very important. All patients with diabetic ketoacidosis and hyperosmolar hyperglycemia, we got to admit them to the unit. They have to be there 12, 24 hours until you get them out of diabetic ketoacidosis, and then they could go on to the normal, medical wards. But until you get them out of DKA, right, they need to be there because they need extensive fluids. They need a follow-up of glucose around the clock every hour or two, and so forth. And you can't do that on the medical ward, so they have to be admitted to the intensive care unit. The treatment of this disease, the number one treatment, and I've highlighted it here, right, is insulin, right? The number one treatment is insulin. That patient has to get IV insulin, and once the patient comes out of diabetic ketoacidosis, they'll get subcutaneous insulin for the rest of their life. But right now, what's the number one treatment in this patient, the only way to save this person is by the use of insulin. Because these people are also dehydrated, we give insulin plus IV fluids. IV fluids are very important here. They're very important. We always give them along with insulin, but without insulin, you can't do much in this patient. So insulin here is the most important thing, and aggressive fluids are right up there. The fourth thing we do is we have a diabetic ketoacidosis that we think we have because we saw high sugar and we saw high anion gap and a low bicarb, but we confirm the ketoacidosis by looking for ketones in the blood or the urine. Most people do it in the urine because it's easy, but really the best test to confirm ketones, diabetic ketoacidosis, is in the blood. That's the gold standard test, but most people, if they find it in the urine, it's okay. Now, we did the blood and the urine cultures because we said that we have to do that because we have to look for precipitating causes, right? And we also said in patients with normal potassium on admission with diabetic ketoacidosis, please remember this last clinical pearl here. Please give the patient potassium, okay? I'm going to say a last word before we go on to the next case. What are the goals in patients with diabetic ketoacidosis? The goals is, when do you stop the IV insulin? The answer is when the patient is out of diabetic ketoacidosis. And how do you know they're out of diabetic ketoacidosis? Their anion gap has normalized and their bicarbonate has gone up to normal. So the anion gap has decreased and the bicarbonate has gone up to 22, 24, the normal value. Now, both the bicarbonate and the anion gap are one and the same thing, right? They're relative to each other. So when one goes down, the other goes up. So that's a way to figure out if the patient is, if you're treating the patient well and the patient is coming out of diabetic ketoacidosis. Please be careful. They ask a question about, well, what do you do if the patient's sugar starts coming down once you give him insulin? So let's say, 5 hours later, the patient's glucose now is 200. What do? They still have an anion gap, right? They're still, the bicarb is still 14. Maybe it's not 12, it's 14. They're still in diabetic ketoacidosis. You don't stop the insulin. What you do is, if the sugar starts to come down, you add glucose to the fluids. You give them D5, glucose in the fluids, and you continue the insulin. So please be careful. We don't stop the insulin unless the anion gap is normal and the bicarbonate is normal. That means the patient's out of DKA. We don't stop it because the sugar's low. We give them glucose. Remember, diabetic ketoacidosis is really about ketosis. It's not about a glucose level. It's about breaking down lipids. That's what you want to get the patient out of, this acidemia, the ketosis. And the only way that you could do that is when you've done that when the bicarb and the anion gap are normal. Now, the second case is a little bit different. A 62-year-old man is brought to the emergency department by his family because he is confused. His wife has not noticed any fevers, chills, nausea, or vomiting. He appears very lethargic. He's arousable but responds incoherently to questions. He's only oriented to his name. His temperature is okay. His blood pressure is 102/62. His pulse is elevated and he's orthostatic. His respiratory rate is 18. His lung examination is normal. His heart has regular rate and rhythm, but it's probably a little bit tachycardic. There are no focal neural signs, and the rest of the physical examination is unremarkable. So let's go into the lab. So the glucose now, look at this. Compare that to the prior glucose in diabetic ketoacidosis. Look at this. This is the typical glucose that you get with people with hyperosmolar hyperglycemia. Over 1,000. Remember, people with hyperosmolar hyperglycemia, they have very high levels. When you see over 1,000, it's usually type 2 diabetes with hyperosmolar hyperglycemia. The potassium is normal. The BUN creatinine is elevated. And now you say, okay, well, this looks like prerenal azotemia, but I'm not sure, because if this guy has type 2 diabetes, he could have pre-existing renal disease. So you're not sure here. It's not 100%. The only way you're going to find out is when you give them fluids. If it reverses totally, well, it's prerenal azotemia. If it doesn't reverse, then this patient has some kind of kidney dysfunction, probably diabetic nephropathy, even though he never had diabetes before. Remember, you could have this years without any symptoms, and it could cause microvascular complications long before the diagnosis is made by the physician. The bicarbonate is 24, that's normal. The sodium is 130, the chloride is 100, and when I do the anion gap, I take 130 and I subtract 100 plus 24 from that, and my anion gap now is 6. That's normal. Less than 12, it's normal. The ketones are negative in this patient, so now I've diagnosed hyperosmolar hyperglycemia in this patient. Now look at this. They got the blood cultures now and the chest x-ray here, the urine analysis and all that stuff, looking for precipitating causes, but they got one more thing, because this guy's an older guy, right? He's in his 60s, an older individual, is not the 19-year-old guy. They got an electrocardiogram, and this is the right thing to do, to look for silent ischemia. We always look for these kind of scenarios in patients presenting with diabetes, something that precipitated the diabetes. So what do we do further on this guy? Well, we admit this guy to the ICU, and believe it or not, this patient, because of the advanced age, because these patients with type 2 diabetes and hyperosmolar hyperglycemia usually have comorbid conditions. It doesn't occur in patients that are 19 years of age. It occurs in, like this guy, 60-something years of age, and these patients have comorbid conditions. This disease, hyperosmolar hyperglycemia, has a worse prognosis than diabetic ketoacidosis. The reason is because it occurs in patients with comorbid conditions, and it has a worse outcome when you compare that to diabetic ketoacidosis that usually occurs in young people, and these patients rebound really quick. So I didn't say type 1 diabetes is better. I said diabetic ketoacidosis as a presentation of diabetes has better outcomes than hyperosmolar hyperglycemia because this population has comorbidities. After we admit the patient to the ICU, we aggressively give the patient IV fluids. Now, because this is an insulin-resistant state, it's not insulin-dependent state like type 1 diabetes, aggressive fluids are the most important thing when patients present with hyperosmolar hyperglycemia. Yes, we give these patients a little bit of insulin, but they don't need a lot of insulin like type 1 diabetics need. These patients reverse right away, even if you give them some fluids sometimes. You'll see that after a couple of liters, their sugars have come down from 1,100 to 400 very, very quickly just with fluid management. So look at that. Yes, they'll need a little bit of insulin. Insulin is good, but you can, these patients, one of the most important thing right away is to give them a lot of fluids back because they're usually severely dehydrated, at least 4 to 5 liters down. We did the EKG, right, to rule out silent ischemia. This patient had nothing like that, and we did the blood and urine cultures, which were very important to rule out any causes that precipitate diabetes. Now remember, this patient would have gotten diabetes anyway, has diabetes, but you say, why now? Why did this patient present now with this severe form of diabetes? And the answer sometimes is some type of infection, some type of myocardial ischemia, so please look for that. Now, a little bit further down, those are the acute complications. We want to talk about chronic complications, and these are very important. There's studies that multi-million-dollar prospective trials that look into these chronic complications because diabetes mellitus is such a profound disease, and if people have read all the news and the studies, they say that diabetes in this country is like an epidemic now. So chronic complications involve two types of groups of diseases: the microvascular complications and the macrovascular complications, like peripheral vascular disease and so forth. Please remember that in terms of tight glycemic control, the evidence has shown 100% that it's the microvascular complications that if I do tight glycemic control, those are the ones I could prevent. So if they ask us on the boards, if you're doing tight glycemic control on a patient, which complications are you hoping to stabilize and to not have later? The answer is only the microvascular complications. Macrovascular complications, there's some studies that show yes, some other studies show that it probably doesn't have an effect on them. There's other parameters, they kind of have a life of their own. So look for microvascular complications in patients and do tight glycemic control to prevent these. There are three types of microvascular complications. The first one is the neurological, the diabetic neuropathy. And the most common one that we see is the peripheral. That's the most common one, the peripheral neuropathy that sometimes involves the distal extremity, so they call it sometimes stocking and glove neuropathy because it involves the feet and the hands. So that's the painful peripheral neuropathy that we most commonly see. Then the other type of neuropathy that we see is the mononeuropathy. So that's a single nerve affected. So for example, these patients sometimes present with a wrist drop, a foot drop, or more commonly, if it affects the cranial nerves, it's cranial nerve 3 that's mostly involved. So these patients present sometimes with ptosis. So that's very important. Don't misdiagnose these patients with ptosis for Horner syndrome, because Horner syndrome has ptosis too, right? These patients are different. They're diabetic patients and they have ptosis, and they don't have meiosis like the Horner's patients do. So please look for that. So cranial nerve 3 commonly involved in diabetic mononeuropathy. And then the third type is autonomic neuropathy, right? So this is the hypotension that sometimes these patients get, erectile dysfunction, gastroparesis. These are all forms of autonomic neuropathy. So any one of these can be prevented if you do tight glycemic control. The second microvascular complication involves the renal complications or diabetic nephropathy. This is also a major cause of morbidity and mortality. There's more patients on end-stage renal disease and hemodialysis from diabetes than any other disease in this country. Hypertension is the other one that comes close, but diabetes is probably more profound in this case. So most of the patients that we see in end-stage renal disease in this country probably have had diabetes of some type, type 2 diabetes of some type at some point or another. And the renal complications are the ones that are one of the most important ones that we try to stabilize because of the morbidity and mortality associated with them. Now, they may ask us on the boards, well, how could we pick up early diabetic nephropathy? What they're really asking is, how can you pick up diabetic nephropathy at the earliest stage, at the earliest part of the nephropathy, so you could initiate treatment and you could do the right things early on? And the answer is to look for microalbuminuria in the urine. Look for, it's a specific test in the urine, microalbuminuria. Okay, now if a patient has macroalbuminuria, they're going to have microalbuminuria. You want to do this test if you see no protein in the normal urine analysis. You want to look for microalbuminuria because you could be missing macroalbuminuria. If a patient has microalbuminuria, that is still albuminuria, and you need to treat this patient to prevent further damage. The treatment of choice, the drug of choice to prevent renal nephropathy, right, damage, are the ACE inhibitors. So once we find a patient with microalbuminuria, or even worse, macroalbuminuria, you put them on an ACE inhibitor. What the ACE inhibitor seems to do, the theory behind the ACE inhibitor, is that what it does is it vasodilates, and what it does is it decreases glomerular filtration rate. And if you decrease glomerular filtration rate, the pressure across the glomeruli decreases, so the glucose molecules being pushed across the membrane, they don't cause any damage further. So that's the theory behind that. If we can't use an ACE inhibitor, let's say we can't use an ACE inhibitor because of side effects, coughing is the most common one that people have to stop the ACE inhibitor, then the drug of choice is an angiotensin receptor blocker, losartan or any of the angiotensin receptor blockers. They're all similar. All the ACE inhibitors also have been shown. An ACE inhibitor is an ACE inhibitor. It doesn't change if you go from one to another. They're all the same. They all seem to be effective. So renal disease is very common. Look for early renal disease with microalbuminuria. If a patient has microalbuminuria, put them on an ACE inhibitor. I'm going to say one more thing here about renal disease. If a patient has hypertension and diabetes, and that means for diabetic patient, hypertension is defined anything 130 or over is defined as hypertension. So it's not the usual systolic blood pressure 130 or over is defined as hypertension in diabetic patients. So it's not like normal people where it's 140 or over. These patients, you have to go at 10 points lower because the effects of blood pressure on the kidney. So if patients have hypertension and diabetes, the drug of choice is an ACE inhibitor, because you want the ACE inhibitor to protect the kidney anyway. So you're going to give it to them. That's a compelling indication to use an ACE inhibitor. That's the drug of choice. You don't use diuretics, you don't use beta blockers, you use the ACE inhibitor before you use these drugs. So a patient with diabetes gets an ACE inhibitor if they have microalbuminuria or hypertension or both. If they don't have hypertension, if they don't have microalbuminuria, don't give them an ACE inhibitor. Those are the recommendations. The last one that we want to talk about is the ophthalmopathy, right? The diabetic retinopathy. In this country, it's the most common cause of blindness. Diabetic retinopathy in middle-aged people. That's the most common cause, and it's the proliferative retinopathy that really causes a chance for blindness. What happens in these patients is you have a neovascularization, and these new vessels that occur in proliferative retinopathy, what happens is there's a chance that they're very friable. There's a chance that they bust, they bleed, and the patient goes blind basically because of the bleeding from the vessels. So proliferative retinopathy and neovascularization is the thing that tells us that these patients right away you have to do something about them. You have to send them to the eye doctor right away, and they have to have photocoagulation and stabilization of the lesions. Now, one more thing. Once we diagnose a patient with type 2 diabetes, they have to go to the eye doctor right away. Right away, once you diagnose them with type 2 diabetes, they have to go to the eye doctor because they can have already proliferative retinopathy that you don't pick up as a generalist. So they have to go to the specialist right away. The type 1 diabetic patient, remember, they don't have the disease for a long time, so you could wait 5 years, and then after 5 years, they go to the doctor every year. So type 2 diabetics, they go every year from the time of diagnosis. Type 1 diabetics, you wait 5 years, then they go once a year after the 5 years. Now I want to show you a slide a little bit. Let me tell you this first. The follow-up on diabetes mellitus is for type 2, a yearly eye exam by the ophthalmologist right at the time of diagnosis, and type 1, the eye exam 5 years after the diagnosis, then yearly. That's what we have to remember. And all of these patients, they do foot exam yearly. Foot exam yearly because what happens is we don't want them to have any skin breakdown in the feet. That's a very common area where there's decreased circulation, and they could get infected and then develop cellulitis and have a foot amputation and so forth. So foot exam also is another part of the annual screening exam that we do in the follow-up in patients with diabetes mellitus. So I want you to look at this and just a little bit know this in case they give it to us on the boards. So when they show you a retinal exam, and an eye exam on a patient, and you see a combination of look at this, these areas here of bleeding. These are areas where this patient's had bleeding, and then you see these other areas, these yellow areas, where basically these are old areas. These are sometimes referred to as cotton wool spots and stuff like that, where basically these patients develop old bleeding and then fibrosis over them. When you see scattered lesions like this could only be diabetic retinopathy. So fundoscopic exam that shows multiple lesions of bleeding and evidence of old lesions, these cotton wool spots here, this is old fibrosis and edema, right? This patient has diabetic retinopathy. Now, it's only the proliferative retinopathy, though, that could cause blindness. So it's only those lesions that you stabilize. You stabilize by photocoagulation. If they have what is called background retinopathy, what this patient has, these cotton wool spots, these bleeding stuff and stuff like this, as long as you don't have neovascularization, you don't worry about bleeding in this patient. And all you have to do in this patient, if they tell you the exam shows bleeding, edema, but no neovascularization, all you have to do is you got to control this patient's sugar very well. You got to do tight control in order to stabilize this so it doesn't get worse and they don't develop proliferative retinopathy. So a couple of other concepts just to finish off with diabetes mellitus. I want to talk a little bit about the Somogyi phenomenon. Somogyi phenomenon, we don't see it that much anymore because we use different types of insulins now. I told you the glargine insulin and so forth, but people using the NPH and the regular insulins commonly see Somogyi phenomenon, and all the Somogyi phenomenon it really is rebound morning hyperglycemia. Rebound morning hyperglycemia. So this patient wakes up in the morning with hyperglycemia, and this is rebound due to what? Because the patient has been hypoglycemic during the night. So what they're really saying is, be careful of morning hyperglycemia, because it could be a rebound phenomenon because the patient has been hypoglycemic during the night because you're giving them too much insulin. So what do you do when a patient comes to you with morning hyperglycemia? You don't increase the amount of insulin at night. You don't think, to take care of that by increasing the insulin at night. What you do is you stop the insulin, you decrease the insulin at night by about 4 to 5 units until you sort out if the patient really has hypoglycemia in the morning hours. The way to do this is you basically make the patient wake up in the middle of the night, and they wake up and they check their sugar, and if their sugar is really low in the morning, it's a Somogyi effect. If it's elevated during the night, then it's this other thing called the dawn effect. The dawn effect is really true hyperglycemia in the morning, and basically what the dawn effect is that the insulin that you're giving is too little and you're giving it too early. So in the morning hours, the effect has kind of gone away and the sugar's gone up. But the patient that comes to you in the morning, they don't know if it's the dawn effect or the Somogyi effect, right? They come to you with morning hyperglycemia. That's all you know. You don't know if you're giving them too much insulin or too little insulin. So what do you do always? You cut down the insulin at night to make sure it's not hypoglycemia, because if you don't do it, the patient goes into hypoglycemic coma the next time this happens. Never wakes up. So with morning hypoglycemia, cut the insulin at night, especially the NPH. Make the patient wake up in the morning, check their insulin, check their sugar levels, and make sure you know what you got. If it's the dawn effect and you've documented it, then you go up on the insulin. If it's the Somogyi effect, you have to cut down on the insulin and keep cutting down. So please be careful of that. What do we do with morning hypoglycemia? We decrease the amount of insulin at night because we're always worried about the Somogyi phenomenon. We're not that worried about the dawn effect. Nothing's going to happen to the patient with the dawn effect. We're concerned about the Somogyi phenomenon that may kill the patient if we continue to give them too much insulin. So morning hypoglycemia, cut the insulin at night by 4 or 5 units. They may tell us, they may give us a patient with morning hyperglycemia, and they tell us, well, you cut the units by 5 units at night, and the patient forgot to wake up in the morning and check his sugar, right? But the next day, his sugar now is normal. It was 300 before, and now it's 150. It's not great, but it's not 300. So they're trying to tell you it was the Somogyi effect. If you cut the units down by 5 units, right, at night, and then in the morning time, the guy wakes up now and instead of 300, it's 450, right? Now it's the dawn effect. So even just by that, what happens to the patient's sugar the next day, from the morning glucose, just by cutting down the amount of insulin at night, the effect in the morning, exactly what's going on, just but what's going to happen, what happens to that glucose over the next couple of days. The Somogyi phenomenon occurs because you're giving too much insulin at night. So 3 o'clock in the morning, the patient's glucose is low. They're developing hypoglycemia. They don't remember it though because they're sleeping. In fact, some of these patients have nightmares. They have really bad nightmares, but they don't remember the hypoglycemia at night. In the morning hours, once the hypoglycemia sets in, you have the surge of counter-regulatory hormones like growth hormone, cortisol, glucagon, and all that stuff. And these counter-regulatory hormones, they bring the glucose back almost to normal, because if they don't, the patient's going to die. But what happens in the morning hours now, the insulin levels have weaned off, and you get the surge of glucagon, growth hormone, and stuff like that, and now the sugar goes from low to normal to high, and that's the rebound effect that you see with the Somogyi phenomenon. So please remember that when they give you patients with morning hyperglycemia. The honeymoon period is a very interesting phenomenon. People with type 1 diabetics sometimes present with diabetic ketoacidosis, and then after you take care of their diabetes, you take care of a possible infection they have or something like that, the patient starts taking insulin, and the insulin needs go down. They go down because this patient has residual beta cell mass. So this is called the honeymoon period. The residual beta cell mass that the patient has, they have some production of insulin still, despite the diabetes, right, is what the honeymoon period is. And what you have to do in the honeymoon period, you have to realize that, because the patient will be calling you and telling you, hey doc, I'm hypoglycemic, and you're giving me the amount of insulin that I was doing well before, but now my sugar's in the 50s and the 60s and stuff like that. And what do you have to do with the honeymoon period is you basically have to decrease the amount of insulin, but not stop it totally, because they'll eventually get type 1 diabetes, total type 1 diabetes, and they'll go into decay later and present in decay again to you. So what you have to do is reduce the insulin units, right? So the patient doesn't become hypoglycemic, and then once they develop clinical type 1 diabetes again, then you start going up on the insulin as you did before. So the honeymoon period is usually in type 1 diabetes, type 1 diabetics get this, when they have residual beta cell mass despite presenting with diabetes before. Once you take care of the infection, now you have some residual mass, or you take care of the diabetes, you have some residual mass of beta cells there that still function. That's what usually happens, and in those cases, you have to decrease the amount of insulin that you give to the patient in order to prevent hypoglycemia, but not stop it totally, so in the long run, they don't go back into diabetic ketoacidosis. Going now from hyperglycemia and diabetes to hypoglycemia, we need to know a little bit about the etiology here and the definition and how to work up a patient with hypoglycemia. They may give us a question on the boards about this. The definition of hypoglycemia is not just a low sugar, but it's a triad of a low sugar plus symptoms consistent with hypoglycemia. And then the third thing is that these symptoms reverse when you give the patient some form of glucose. So the hypoglycemia means low sugar, means symptoms consistent with hypoglycemia, and then reversal of the symptoms with some form of sugar. That's the exact definition of hypoglycemia, and these are the kind of patients that we're talking about here. So the etiology is simple. You're either you're fasting, you're not eating a lot of sugar. This is fasting or postprandial hypoglycemia that we see now when people eat like a lot of protein and not a lot of carbohydrates. And then we see some other rarer forms of hypoglycemia like insulinoma and factitious hypoglycemia, usually from insulin injection. So sometimes they ask us on the boards, they give us a patient with hypoglycemia, and they give us a couple of different blood levels of insulin and C-peptide and so forth to be able to decipher between this differential. So let me go through that with you because this is important for the boards. If a patient has the insulin in the plasma is high, and at the same time, I'm going to go on to the second slide and then go back, at the C-peptide is increased. Now remember, the C-peptide is increased when there's endogenous insulin secretion in patients. Remember, when you secrete insulin from your pancreas, you co-secrete it on a 1-to-1 ratio with your C-peptide. So if you have endogenous insulin, right, your C-peptide should be elevated at the same time. So these patients with insulinoma have endogenous insulin, so the C-peptide is elevated. They usually don't have insulin antibodies. Now, insulin antibodies occur when you give exogenous insulin because they develop, people develop antibodies to the insulin. It doesn't do anything, but those antibodies are there and you can measure them. And then the plasma in the urine, sulfonylurea, is normal. So there's nothing there. So if a patient has increased C-peptide and increased insulin at the same time, it means it's endogenous insulin, and this usually occurs with insulinoma. If a patient is taking factitious exogenous insulin, then the plasma insulin is high, right? Forget about the proinsulin, that's not so important. But the plasma insulin is very high, and then the C-peptide now with exogenous or factitious insulin taking is usually low, and then these patients may, not all the time, but they may have insulin antibodies because they're injecting themselves with exogenous insulin. Now, people with exogenous doing factitious hypoglycemia, injecting themselves with exogenous insulin, are usually patients they usually have patients in their family that are diabetics, or they do some kind of medical work. Either they're physicians, or they're nurses, or they're medical students, or they're paramedical staff. So one of those two scenarios, they either have patients that are diabetics in their family, or they work in the medical profession some way. So that's exogenous insulin. And then the third one that we have to know to compare this with is the sulfonylureas. Now, if a patient is taking sulfonylureas, right, this looks just like endogenous insulin, because remember the sulfonylureas here, they work on the beta cells to secrete insulin. So your plasma insulin is high, your C-peptide is increased because this is endogenous insulin. So look at this. Sulfonylureas here look just like the insulinoma. They look exactly the same, and there's no insulin antibodies, and you can't tell the difference between those two, except if you think about it, you measure urine or plasma sulfonylurea levels and you find it positive here, and that's how you diagnose patients that are surreptitiously or factitiously taking sulfonylureas on their own to develop hypoglycemia. Now, I'm going to say one last thing here for hypoglycemia, which is it's very important for the boards. All these three states that we just talked about, and I'm going to go back 2 slides here, all these three states here, insulinoma, factitious, right, these patients, all of them, despite hypoglycemia, have elevated levels of insulin, right? That's an abnormal response. If a patient has fasting hypoglycemia, this is normal. Somebody, forgot to eat on rounds in the morning or something like that, and they develop hypoglycemia and they get a little bit, jittery. And if you measure their sugars, it's in the 50s or the 40s. But if you measure their insulin, because it's an appropriate response, it's always low. So people with low insulin plus hypoglycemia, this is fasting hypoglycemia. You don't have to do anything about that. Just tell them to eat frequent snacks throughout the day so they don't develop that. But the abnormal response, where you really have to generate a workup with the C-peptide and the insulin antibodies, is when you find a low sugar hypoglycemia plus an elevated insulin. That's a paradoxical response. It shouldn't occur, and it only occurs in the face of an insulinoma or factitious insulin injection or exogenous sulfonylurea taking and stuff like that. I'm going to say one last thing here before we move on to other diseases. And if a patient presents with hypoglycemia from sulfonylureas, because most sulfonylureas are they're 24 hours, sometimes 48-hour action, those patients all have to be hospitalized. So this is common in older patients where they took the wrong medication. If taking one glipizide tablet, they took two because they thought it looked like something else. So it's very common in the older population to bring the patient in the emergency room with hypoglycemia. Now, if you don't remember this, that these are long-acting medications, if you send that patient home after you reverse the hypoglycemia, this patient will develop further hypoglycemia a couple of hours later home and may never get back to the hospital. So sulfonylurea induced hypoglycemia, those patients have to be hospitalized and watched for 24 hours minimum before they're sent home. If somebody gets hypoglycemia from insulin, I mean, they made a mistake. You know, they gave themselves too much insulin. You know about that. I mean, they tell you about it. I thought I gave myself 10 units, and I probably gave myself 15 or something like that. That's probably okay, unless they're taking long-acting forms of insulin. If they give themselves a shot of 5 extra units of regular insulin, that patient, usually you watch in the clinic for a couple of hours and give them a little bit of sugar, or you watch them in the emergency room for a couple of hours until the insulin wears off, and you send them home right away. You don't have to hospitalize those patients. It's the patients with sulfonylurea you have to hospitalize in the hospital to watch for 24 hours, because these are long-acting medications, and you may get hypoglycemia hours later after you've reversed the hypoglycemia in the emergency room or the clinic.